Okay, I think I'm just gonna get started. Just to make sure everyone's going to get to their clinic sites on time. So I'm Ryan. I'm one of the PGY3s. I'll be covering sleep psychiatry as it relates to the PRITE. I'm just going to focus on like the high yield stuff at this point. I think there's not too many big things to cover in sleep medicine, so it's a fairly limited topic. Let me just get my screen share real quick. All right. So sleep is a pretty pivotal part of all mental illness. So it's good to have kind of a good understanding of, how sleep medicine operates in the field and kind of best practices. So let's get some more people in here. So let's start off with the first question. All right. So question number one, during what stage of sleep do sleep spindles occur? I'll give y'all about a minute to get this one. Okay, I'm going to end the poll. So most of you guys chose N2. Perfect. And the correct answer is N2. So it's a good pivot to kind of the structure of sleep. So what is sleep exactly? Sleep is an active process, and we measure sleep based off of different stages. So we have sleep cycles and sleep stages. And we kind of parse those things out by looking at different aspects of physiology. So we look at EEG, eye movements, EKG to look at the heart rhythm, EMG to look at muscle tone, respiratory flow, pulse ox. We can also look at their carbon dioxide levels. So if we can check for things like hypercapnia, the basic structure of sleep cycle is usually about 90 minutes, anywhere from 90 to 120 minutes. You start from N1 to N2 to N3. Some of the older literature used to N4 as another cycle, but N3 and N4 have been combined more recently into deep sleep. And then REM is the last part. And so you can see REM here actually will come in towards the end of that cycle. And then your REM actually increases throughout the night and your deep sleep starts to decrease. And something to keep in mind, one of the high yield points that's often tested on PRITE is when someone has depression, we see reduced REM latency, and we can talk about that in a little bit detail more later on. When it comes to the question, I was asking about sleep spindles. And so with each stage of sleep, there are different EEG findings, and sleep spindles are one of those EEG findings. We can kind of compare how these stages look differently depending on how we record brain findings. And REM sleep looks a little bit like being awake, interestingly enough. Sleep spindles occur in N2 specifically. This is a really useful chart. I actually memorized this chart because a lot of PRITE exams will reference this thing specifically. So when you're awake, you have alpha waves. And so they're high frequency, as in a lot of the waves are bunched up together and fairly variable for the most part, depending on what you're doing. And your eye movements, obviously, when you're awake, are just variable, just in nature. NREM or non-REM sleep or N1 sleep, theta waves. So they're a little bit more slower than alpha waves, but for the most part, there's still a lot of chaos there. It's still high frequency for the most part. You still have muscle tone. You might have some slow eye roll movements. So if your question stem asks about slow eye roll movements, it's going to be N1. N2 is where you still have some theta waves, but this is where you start to see sleep spindles and K complexes. So if you have any strange thing that they're asking for, it's probably going to be N2, like this last question about the sleep spindles. You still have muscle tone, but it's starting to slow down a little bit. You can think of N2 as the transition between light sleep and deep sleep, which is N3. And N3 has delta waves, which are generally much slower. So they are lower frequency compared to being awake or compared to light sleep. And you have markedly decreased muscle tone, but it's still somewhat there. So that's important to note. And then you have REM sleep, and this is fairly low voltage, but it's high frequency. Remember, so deep sleep is low frequency, and when you get to REM, you get back to high frequency. And here you have a complete absence of muscle tone. REM sleep is where you sleep. You have rapid eye movement. That's why it's called REM. It's rapid eye movement sleep. This is where you're having dreams, and if you weren't paralyzed, essentially, you'd be acting out your dreams. And so that's why you have lack of muscle tone. Okay. Move on to the next question. Oh, you know what? I think I might have messed this up. Okay. Can people see the second poll? So the second question is, REM sleep is first evident at which stage of development? So we have in utero, immediately postpartum, at 1 month, at 3 months, at 1 year. Okay. So I'll kind of leave the poll open. I have all my questions clustered, so we'll actually just kind of get the answer for this one. It's in utero. And so this is a nice table. Would also recommend memorizing this. So you can actually detect REM sleep while they're in utero. And it's kind of a good transition to something that they'll ask on the PRITE, and that's how sleep changes over time as we age. And of course, babies sleep a lot. We all know this, but as we age, we actually start to have decreased sleep. So there's a difference between time in bed and time asleep. So someone who's older might spend more time in bed than someone who's maybe between between the ages of 25 to 45, but they'll actually have less sleep overall. So if you look over here, at birth, when you're a baby, you're sleeping up to 16 hours a day, and then as you're becoming a teenager, you're sleeping sort of 8 hours as an adult, average of 7, and then as you become elderly, then you get to 6.5 hours on average. But there's also changes in kind of the stages of sleep, generally speaking. And so overall, as you age, all the stages will start to decrease. And specifically, you're going to have reductions in REM. So you see, and when you're in birth, you have 50% of your sleep is in REM, and as you age, it'll go down a little bit, down to 20. Now, as you get older, the deep stages, which is stage 3, and stage 4 is kind of this super stage that's coupled with it, will be markedly decreased as well. And so if you got a question stem on the PRITE asking you which stage of sleep is decreased significantly in the elderly, is going to be deep sleep. Okay, and then if you want to scroll through the poll, it should still be open, I believe. I'll go to question 3. Which of the following brain areas are implicated in the pathophysiology of narcolepsy? Is it hippocampus, amygdala, lateral hypothalamus, anterior hypothalamus, or the locus coeruleus? I'll give you all about a minute to put in your answers. I think if you scroll down on the poll, you should be able to see the questions.
Ryan, we can't see the poll.
You can't see it?
No.
Oh, did you close the last one? Let me see if I can just initiate it. Okay, yeah, if you scroll down to number 3, you should see the question. There we go. Okay, we got a pretty good sample size here. So it looks like most of you guys chose lateral hypothalamus. I think still some people are filtering in. We'll move on for the sake of time. So the answer is lateral hypothalamus. So this is a good pivot to how sleep is actually run in the brain. So we have wakefulness promoted by different neurotransmitters like acetylcholine, norepinephrine, serotonin, dopamine, histamine. But all of these neurotransmitters are actually modulated downstream or actually upstream from a neuropeptide called orexin or hypocretin. So those two names are interchangeable. The main issue with narcolepsy is hypocretin. And then you have sleep promoted by things like GABA and galanin. Galanin's produced in the ventral preoptic area of the hypothalamus. And so what is narcolepsy? Narcolepsy is usually characterized by things like sleep attacks. So people will feel like they just will fall asleep randomly, whether it be driving, randomly doing activity, they'll fall asleep fairly quickly. If you look at this sleep study over here, you can see they're awake during the day for a normal control, but then someone with untreated narcolepsy, they're going to have periods of just falling into REM sleep during the day. And that's really kind of the main finding on a sleep study is a very reduced REM latency. So this is something we're testing on PRITE quite often. The main pathophysiology of narcolepsy is a deficiency in orexin or hypocretin, which is produced in the lateral hypothalamus. So orexin keeps you awake. So if you have a lack of orexin, you will tend to fall asleep. And this is actually how suvorexant works, or Belsomra. We actually block orexin with that medicine. So we're essentially pharmacologically inducing a temporary state of narcolepsy in our patients. And of course, with a half-life of about 8 to 9 hours with Belsomra. You might see low levels of CSF orexin, but really the way to actually diagnose this condition is to get a sleep study. And then you'll see the reduced REM latency. Treatments include modafinil. This is a wakefulness agent. Some neurologists will use amphetamines, but modafinil is not an amphetamine. It's not really a classic stimulant. It helps modulate downstream histamine, so that's how it keeps you awake. And then you can use nighttime sodium oxybate as well. And then something that I might test on PRITE is the most common symptom in narcolepsy is sleep attacks, and it's commonly associated with sleep paralysis, hypnagogic, and hypnopompic hallucinations. So these are, you might see or hear things as you're falling asleep or as you're waking up. Okay, and the next question, which medication is best for treating circadian rhythm sleep disorders like delayed phase sleep disorder? Okay, this should be number 4. If you guys have any trouble looking at the polls, just let me know. I think that, yeah, I think most of you have responded to this already. Vast majority of you guys are choosing melatonin here, which is the correct answer. And so there's disorders of sleep related to their circadian rhythm. They may or may not ask this, part of the neuroscience questions, but your circadian rhythm is modulated by the suprachiasmatic nucleus. That's where you start to form your daylight cycles, which is actually right above. It's a set of cells above where the optic nerves will cross over. So it's a perfect place to detect where light's coming from. But this is issues with actually the phase of sleep. So you're falling asleep way earlier than you should be, but you're waking up also earlier, or you're falling asleep much later, and you're also waking up later. You might see this in like people who are doing shift work, people who have jet lag. The mainstay treatment would be melatonin. Melatonin is not generally great for insomnia, but it can be useful for this. And so this is one of the actual good use cases of melatonin. Another thing you might see on your PRITE is light therapy, and you need at least 10,000 lux. Okay, that's the number that they're looking for. So it needs to be at least that. So anything above that is going to be adequate to help kind of reestablish those circadian rhythms. Okay, next question. That should be question 5. Patient complains of daytime sleepiness, self-attributed to insomnia and multiple nighttime awakenings. The patient endorses frequent morning headaches. The patient denies sleep paralysis and sleep-related hallucinations. Polysomnography shows sustained periods of decreased breathing associated with hypercapnia that occur 4 times during the night. What is the most likely diagnosis? Okay, I think most of you guys have answered, and most of you all chose obstructive sleep apnea, which is the correct answer. And so let's kind of look at this question step. So you have daytime sleepiness, multiple nighttime awakenings, morning headaches, sustained periods of decreased breathing, and this is the key thing here, hypercapnia. So that means there's more carbon dioxide in the blood. So what's going on? So let's kind of discuss sleep apnea a little bit. This is something we'll commonly see here in clinic. We'll make sleep referrals for people who we think have sleep apnea. But there's a difference between obstructive and central sleep apnea. So the questions from above is specifically referencing obstructive sleep apnea. And it's important to kind of differentiate those two things in a question stem so you get the right answer on your PRITE. Obstructive sleep apnea is mostly due to some sort of obstruction. So they still have an effort to breathe. They still want to breathe, but there's something getting in the way of them breathing. Versus central sleep apnea, there is no respiratory effort. So the brain is actually not giving the signal to the diaphragm to move up and down and to actually have that respiratory effort. So that's a complete lack in central sleep apnea. So it could be for obstructive sleep apnea, could be because of obesity, increased, they have large tonsils, nasal obstructions. It could be a lot of different things causing those blockages. For central sleep apnea, there's something wrong with the brain specifically. So it's a brain problem. Symptoms for obstructive, classic snoring, but they're going to wake up a lot at night. And sometimes partners will say that they're gasping for air. And oftentimes they're going to say, like, I wake up and I don't feel refreshed. For central sleep apnea, you might have something called chain strokes breathing. So you're going to have periods or cycles of hyperventilation followed by the apnea. Okay, so you're not as likely to have the choking or the gasping sensation. And actually what happens with the chain strokes breathing is as you're hyperventilating, you're breathing off CO2. So you may or may not have hypercapnia with central sleep apnea. You will definitely have hypercapnia with obstructive sleep apnea because the CO2 is just trapped there. It's not really coming out because there's an obstruction. Someone's blocking it from being released out. So it stays in the lungs and filters into the blood, and that causes the hypercapnia. For folks who you see in clinic or on the wards, if you're concerned about sleep apnea, you can do a stop bank screen. You can just do it on MD Calc and see their risk. Some things that might increase their risk include obesity, large neck circumference, and being male. And then common risk factors for central sleep apnea include heart failure, some sort of neurological condition, opiate use, high altitude, stuff like that. Okay, and then this is some of the breathing patterns that you might see, and of course the arterial O2 saturation. This will go down across all the sleep apneas, but you can see here the airflow is decreased throughout, but then you can see the big thing in the obstructive sleep apnea is this pressure in the esophagus. And treatments include things like weight loss, BiPAP, CPAP, and there's some surgeries you can do to help with maybe reduce tissue, but help with the breathing process. Okay, next question. All right, a 66-year-old male presents with his wife, who complains that she is frequently awakened by the patient kicking in the middle of the night. The patient appears to be awake during these episodes, but his eyes are closed. However, the patient does not remember any of these events. No substance use is noted. The wife is also concerned about some cognitive decline over the past year. How would this condition be treated? Okay, I think most of y'all have answered. Still some people filtering in. Okay, for the sake of time, I'm going to move on. Split between sodium oxybate and clonazepam. The actual answer is clonazepam. So what's going on here? They're describing REM sleep behavior disorder. This is a parasomnia. So this is a condition that occurs around sleep. This is characterized by people actually acting out their dreams. So remember, in REM sleep, your body's supposed to be paralyzed. You're not supposed to move and act out your dreams. So if you are, something is physiologically going wrong with the brain. So one of the key associations with this particular disorder is actually Lewy body dementia. And they won't tell you Lewy body dementia on your PRITE. They might say alpha-synuclein inclusion or alpha-synucleinopathy. They might not say Lewy body dementia directly. There's also some associations with Parkinson's disease. So if you do see this, you have to be concerned about Lewy bodies. And that's the cognitive decline that they referenced in the question stem. First line treatment is clonazepam. That's what they'll put on the test question. So the parasomnias, there's more besides REM sleep behavior disorder. There's things like sleepwalking, night terrors, and both of these things will occur in N3. So that's deep sleep. And the big thing here is you're not going to have any memory about any bad dreams. And night terrors usually occur in kids. And the way you differentiate that between a nightmare is the kid will usually remember some of the contents in the nightmare, because the nightmare happens in REM sleep. Night terrors will occur in N3, which is deep sleep. And then you have REM parasomnias like sleep paralysis, REM sleep behavior disorder, as we discussed. Sleep paralysis is interesting in that you're going to see your dreams kind of superimposed onto reality because your eyes are awake, but you're still paralyzed. So it's fairly terrifying if you go through that experience. Some people report seeing things like devil or aliens or ghosts, whatever. And that's a parasomnia that occurs during REM sleep specifically. Okay, next question. What test is indicated with restless leg syndrome? That's question 7. Okay, this is fairly overwhelming. I'm just gonna stop the poll. I think most people probably know this one. It's iron studies. So restless leg syndrome, won't spend too much time on this. You just have the feeling that you have to move your leg. There's weird sensations that are kind of disrupting your sleep. It's mostly at night or when resting, so your legs are staying still. But it's commonly associated with iron deficiency. So if someone's coming with restless legs, you should test them for iron deficiency by getting an iron. You can check their iron levels, see if you need to replenish them. But you can also treat them with dopaminergic agents. They tend to make people sleepy. So ropinirole, pramipexole, and sometimes people use gabapentin. But the main thing is going to be the dopamine agonist to treat this. Okay. And then question 8, alcohol withdrawal affects which aspect of sleep? That's question 8. I'll give y'all a minute to think through this one. Okay, I think most folks have answered this. Okay. So most folks chose decreased REM and increased slow wave. The actual answer is increased REM, decreased slow wave. So remember, this is talking about alcohol withdrawal. Okay, so let's get into that a little bit. So alcohol will cause sleep issues, generally speaking. And when you're intoxicated, you have any alcohol in your system, you're actually having reduced REM sleep and increased slow wave sleep, which is disbalanced. You're not going to have restful sleep because you need REM for a number of different functions, including memory consolidation and emotional processing. And so if you do that chronically over time, you have phenomenon of REM rebound. This is what happens when you have chronically decreased REM sleep for whatever reason. And then suddenly that whatever that stressor is or whatever was interfering with that process is gone, then your REM will have a rebound effect. And so you have more REM. So that means if you're having alcohol withdrawal, so maybe you don't have the alcohol in the system anymore, your REM sleep is going to come back, but in full force and then some. So you're going to have much more REM. And so that's why people are going to describe vivid dreams when they're having their withdrawals from alcohol, because they're no longer suppressing their REM sleep. But then you're increasing your slow wave sleep with alcohol. So there's going to be an opposite effect when you're withdrawing, which is decreased slow wave sleep. And so just kind of remember these two things are going to be diametrically opposed whenever you are seeing a question stem, because they might flip it and say, what's the effect of alcohol intoxication on sleep and not withdrawal? So it's just going to be flipped in that case. Chronic alcohol use often leads to persistent insomnia after detox because people just got so used to using it to help them sleep, but it doesn't really help you sleep. It makes you look like you're sleeping, but you're not actually getting restful sleep. Okay, and then there's no question for this. I just wanted to kind of briefly comment on insomnia and the different sleep meds that are available that you can use. But insomnia has a particular definition for the DSM, and that means you have difficulty sleeping for at least 3 nights out of the week for 3 months with distress or dysfunction. Okay, so I need to have all those things to have a diagnosis of insomnia. First line treatment per every single society's guidelines is CBTI or cognitive behavioral therapy for insomnia. Now that's easier said than done. Not very many therapists do CBTI, and getting into a therapist even by itself is difficult oftentimes. And so we'll often do a pharmacotherapy to help with insomnia. So there are benzodiazepine agonists. We have the Z drugs and actual just straight up benzos like Restoril or temazepam that people can use. But all of these have huge downsides. Benzodiazepines, like alcohol or any GABA agonist, does not actually help you sleep. And there are notable side effects that you have to keep in mind when using any Z drug. Specifically, people acting out not their dreams per se, but they do weird things while they sleep and they have no memory of it. And there's some cases of actual homicide, of people actually killing other people while on Ambien at night, and they don't remember anything from it. But it doesn't have to be that extreme. It could be driving a car. It could be preparing a late night snack, but not remembering what they were doing. And so there's things like amnesia, and it's just very, very, very problematic. So I would generally avoid these medicines for the most part. Just because the downside is just so much, and there are habit forming, unfortunately. We also have melatonin receptor agonists, like Ramelteon. It's not super commonly used, but you might have a little bit of drowsiness, and there is an interaction with fluvoxamine that may or may not show up on your PRITE exam. Suvorexant or Belsomra, talked about that a little bit. This chart is a little bit outdated in the way that we actually have 3 orexin receptor antagonists right now in the market. So daridorexant, suvorexant, and lemborexant. And the other two orexin receptor antagonists have a shorter half-life compared to suvorexant. So this one, suvorexant or Belsomra has 9 to 13 hours. And so it can last a long time, unfortunately. And so some patients will report significant fatigue during the day. And that could be because the half-life is long. So that's the main side effect, is drowsiness. People can also have weird dreams on suvorexant. I've heard people say that. Then you can use certain antidepressants because they're sedating, and some people will dose them at night to help them sleep. So amitriptyline, very commonly used, but it's unfortunately a double-edged sword. It makes you sleepy, but it's also very anticholinergic, so not very great for the elderly population. Cause things like anything that's anticholinergic will cause dry mouth, constipation. Any tricyclic can increase the risk for arrhythmias. It can also cause weight gain. It has a lot of uncomfortable side effects, unfortunately. Doxepin's very similar in that way. Mirtazapine, we commonly use it for depression, but also to help people sleep, but it can also cause weight gain, unfortunately. Trazodone, commonly used, unfortunately causes priapism sometimes in males, not super commonly. May potentially cause orthostatic hypotension, but it's fairly rare. And then gabapentin, sometimes people use that for sleep, but if you use too much, you could have some ataxia, drowsiness. And then there's Seroquel. It's an antipsychotic, and people will sometimes prescribe it for sleep. The only issue with it is we still have the antipsychotic side effects with this medicine, and people tend to build rapid tolerance to this medicine. So someone might start at 25 milligrams, but then they might get up eventually over time to, I've seen people get up to 400 milligrams, and they have no primary thought disorder, no severe mental illness. Someone just started for insomnia, wasn't working, so they upped the dose. They kept upping the dose, and so it wasn't great. So out of all of these, probably the best one are the orexin receptor antagonists, because you're specifically targeting sleep physiology, as Dr. Malik says. You are actually working on the sleep system versus all of these other options are just affecting almost every system in the brain. And so orexin receptor antagonists are far more direct and far more specific for sleep. The only issue is insurance doesn't cover it. So, okay, I think that's it. Anyone have any questions? Okay. Let's see, I'll give it over to Amal. Let's see. Amal, you there?
Hello, yeah, I'm here. Can you hear me?
Yes.
Yes, you're good. You can start your presentation and share your screen.
Okay, sure. Let me share the screen here. Okay, can everyone see my screen right here?
Yes, we can.
Okay, hello
Yes,
everyone.
but sorry, one second, Dr. Mumtaz, you gotta go back to, this is presenter mode.
Yes, are you, hold on, let me see.
Yeah, go back to, yeah, that's it. You're good now.
Okay, is this better now?
Mhm.
Okay, all right. Hello, everyone. I'm Amal Mumtaz. I'm a third-year resident. The topic for my PRITE review today is psychopharmacology, very important topic. So the questions I picked are those that I felt would be helpful in our everyday practice as well. I will not be launching any questions, but the presentation is right here for everyone. So the first question is, which of the following is the most likely mechanism of action of acamprosate? A, it binds to benzodiazepine receptors. B, it blocks glutamate receptors. C, blocks mu-opioid receptors. D, it irreversibly inhibits aldehyde dehydrogenase. I'll give everyone around 30 seconds to go over the options, and then I'll share the correct answer. Actually,
the poll came up them all, so
that's
whatever you
awesome.
did,
Thanks
whatever
to
you did, it
Ryan.
worked.
I think this is all Ryan. I'm not tech savvy at all, so it's Ryan probably. Thank you. All right, so that's probably everyone. So I'm going to end the poll right now and share the results. Most of you picked the right answer. So yes, acamprosate is FDA approved for maintenance of alcohol abstinence and binds to and blocks glutamate receptors as well. After chronic use of alcohol, withdrawal can lead to excessive glutamate activity and deficient gamma aminobutyric acid activity. So acamprosate mitigates these effects by reducing excitatory glutamate neurotransmission and increasing inhibitory gamma aminobutyric acid neurotransmission. Can everyone see the results right now? Okay, all right. So I'll move on to the next slide. So the question is, 65-year-old man with schizophrenia presents with a complaint of dizziness with postural changes. Vital signs are normal. Previous EKG has shown QT prolongation, but his current EKG reveals a normal QT interval. The dose of his antipsychotic medication has recently increased. Which of the following is the most likely cause of his dizziness? All right, so I'm going to show the answer or maybe share results first. So 48% of you chose quetiapine, which is the correct answer, and some of you picked prazosin, but the question said the dose of the antipsychotic medication. Okay, all right. So the correct answer is yes, it's quetiapine. So it is an atypical antipsychotic which reduces psychotic symptoms by antagonizing D2 receptors. So the interesting fact about Circwell is it is also a potent alpha-1 adrenergic receptor antagonist. So alpha-1 receptors are present in blood vessels, and when antagonized, vasodilatation occurs. Thereby it increases the potential for orthostatic hypotension and dizziness. Moving on to the next question. A 24-year-old man presents with a major depressive episode that has been unresponsive to a 2-month course of CBT. He's been resistant to the idea of taking medications due to concerns about side effects such as weight gain and sexual dysfunction. He uses diet and exercise to manage his mild hypertension. Which of the following medications is most likely the best choice for him? And the options are desvenlafaxine, duloxetine, escitalopram, and vilazodone. I'll give it 10 to 15 more seconds for everyone to kind of pick the answer. Okay, all right. So around 55% picked vilazodone, which is the correct answer. There were some, the majority, rest of them, there was an equal consensus between duloxetine and desvenlafaxine. I'll share the results right here. And then move on to the correct answer. The correct answer is vilazodone. So Antidepressants that are either void of serotonergic effects or they have alternative serotonergic actions with or without reuptake inhibition, they're less likely to cause sexual dysfunction. So vilazodone was the first agent developed for major depressive disorder that acts through serotonin reuptake inhibition and serotonin 1A partial agonism. Vilazodone is associated with a lowered risk of sexual side effects and of weight gain due to the partial agonist activity at serotonin 1A receptors. The only other FDA-approved antidepressant with serotonin 1 partial agonism is vortioxetine, which acts on serotonin 1B receptors. Moving on to the next question. So the question is, which of the following is most recommended for monitoring clozapine use during the initial 6 to 8 weeks? The options are creatinine kinase, electrocardiogram, fasting lipid profile, or troponin. All right, I'm going to share the results now. So there was some division of consensus between the options. The correct answer is troponin. So myocarditis is a potential complication of clozapine use and most often occurs within the first 2 months of treatment. So troponin and CRP levels are recommended at baseline and weekly during the elevated risk time frame. And clozapine should be discontinued if troponin is double or more the upper limits of normal or CRP exceeds 100 milligrams per liter. All right, moving on to the next question. Which of the following is approved by the FDA for combativeness or explosive hyperexcitable behavior in children? So the options are chlordiazepixide, our favorite thorazine, clomipramine, and clozapine. I'm going to share the results now. And the correct answer is chlorpromazine. Chlorpromazine is a phenothiazine, dopamine 2 receptor antagonist, and a first-generation antipsychotic. So as a low-potency drug, relatively higher doses are required for effectiveness, which then increases the risks for significant sedation and hypotension due to its anticholinergic, antihistaminic, and alpha-1 antiadrenergic effects. It also achieved approval from the FDA for combativeness or explosive hyperexcitable behavior in children and for hyperactive children with excessive motor activity accompanied by conduct disorder. Moving on to the next question. 17-year-old boy with bipolar depression has been on quetiapine 100 milligram TID for about 3 months. His last dose increase was 50 milligrams about 10 days ago. He had a normal fasting blood glucose and lipid panel at that time. His depression has significantly improved since that time. However, he now presents to urgent care with his parents due to their concern about increased sedation for the last 2 days. They report that he seems too tired to eat, but has been drinking a lot of water. On exam, he appears to be somewhat dehydrated and has a mild increase in his respiratory rate. The remainder of his exam is normal. He's not on any other medications and does not use alcohol or drugs, which is the following is the best next step. All right, I'll share the results now. So the correct answer is checking is serum glucose levels. So checking serum glucose level, most urgent step due to possibility of hypoglycemia and diabetic ketoacidosis. So interesting thing, this is interesting thing about antipsychotics. This is a side effect associated with the use of atypical antipsychotics, and this is something not a lot of us might know, but it may have a rapid onset of polyuria, polydipsia, nausea, vomiting, weight loss, the rest of the signs and symptoms of diabetic ketoacidosis. So yes, typical antipsychotics, they do have these side effects. They might have these side effects. Moving on to the next question. Which of the following accurately describes the mechanism of action of oxazepam? This might be a little tricky. All right, I'll share the results now. The correct answer is it requires binding to GABA receptors to produce any effect. With regards to alcohol withdrawal, we always prefer longer acting benzodiazepines such as chlordiazepine for more consistent symptom control, less risk of interdose anxiety. However, in the presence of liver disease, oxazepam is a good choice due to its short half-life and lack of active metabolites, and it is a non-selective positive allosteric modulator of the GABA receptor. Moving on to the next question. Which of the following is a dopamine, serotonin, and norepinephrine receptor antagonist? The options are clomipramine, clonazepam, clorazepam, and clozapine. I'll share the results now. Correct answer is clozapine. Clozapine is a dopamine, serotonin, and norepinephrine receptor antagonist. It is approved by the FDA for treatment-resistant schizophrenia and reduction in risk of recurrent suicidal behavior in patients with schizophrenia or schizoaffective disorder. Its off-label uses include treatment-resistant bipolar disorder and severe violence in patients with psychosis and other brain disorders. Moving on to the next question. Which of the following is most likely to be a contraindication to the use of venlafaxine? Alcohol use, fibromyalgia, hyponatremia, liver disease, or tobacco use? All right, I'll share the results now. So the correct answer is hyponatremia. Some antidepressants, and this includes venlafaxine, were associated with rare and life-threatening effects such as syndrome of inappropriate antidiuretic hormone secretion, hyponatremia, and seizures. Thus, venlafaxine would generally be contraindicated in the setting of pre-existing hyponatremia. Other contraindications include heart disease due to a dose-dependent increase in blood pressure, and studies demonstrating an increased risk of cardiotoxic-related fatalities in overdose. Moving on to the next question. So a 65-year-old man presents with his partner to the clinic. He was diagnosed 2 years ago with a neurodegenerative disorder due to profound slowing of movement, a hunched posture, a shuffling gait, and abnormal movements in his hands at rest. He was prescribed medications for these symptoms with some improvement. However, over the course of the past year, his partner reports new concerning symptoms. He's become reclusive and paranoid, claiming that deer are coming to their house at night. Sometimes his partner finds him talking to unseen animals, trying to persuade them to leave their home. Which of the following medications would be most beneficial in addressing this patient's new symptoms? answers are still coming in. All right, majority has gotten the answer right. I'll share the results. So the correct answer is pimavanserin. So Parkinson's disease is associated with movement abnormalities. 20 to 50% people also develop psychotic features, including hallucinations and delusions. Visual hallucinations are most commonly of people, animals, and inanimate objects. They occur most commonly during the evening when light levels are low. Pimavanserin is the only medication approved by the FDA for reducing the severity of delusions and hallucinations associated with Parkinson's disease. This is due to its minimal impact on the motor symptoms of Parkinson's disease as compared to other antipsychotic medications. Moving on to, actually, this is the end. Does anyone have any questions? All right,
Thank
then.
you.
Thank you very much.